Welcome to the What's Happening Birmingham video podcast. Your family traditions, culture, and stories are your legacy. So is your health history. Join the All of Us research program and share your health information. Through research, your legacy can help build a healthier future for all of us.
Hello, everyone. This is Jarvis Scott with What's Happening Birmingham. Today, I have the honor and pleasure. I'm back again with some of the great people at All of Us at UAB. Dr. James Cimino. He is one of the co-investigators. He is also the inaugural director of the Informatics Institute at UAB and professor of medicine. Dr. Cimino, welcome on the podcast today.
Thank you, Jarvis. Good to be here.
Great. So I wanted to bring him on because he has a unique role with the All of Us program here. So before we start, can you give the audience kind of like a very impressive bio for a quick little introduction about yourself?
Sure. I trained in internal medicine in New York City, and after my residency in medicine, I did a fellowship in biomedical informatics at Harvard, Massachusetts General Hospital. Then went to Columbia University, where I was on the faculty of medicine and biomedical informatics for 20 years. I then went to NIH for 7 years, where I was working at the National Institutes of Health Clinical Center to build a repository of research and clinical data used for research. And then after 7 years, I came here to UAB. I've been here now 8 years, where I practice medicine, teach informatics, and do biomedical informatics research.
Okay, so let's just start with the first question after that. So what is the UAB All of Us research program?
We are part of the larger All of Us consortium. UAB is the lead institution for the Southern Consortium, and we have two roles. One is that we're leading a group of health provider organizations who are doing recruitment, and we are ourselves a health provider institution, the biggest one in the consortium.
Okay.
And what we do is we're recruiting patients to be part of the 1 million member cohort for this large federal research project. We're not doing any actual research ourselves in this. It's really the recruitment part and providing data from electronic health records for the overall All of Us consortium.
So in your opinion, what makes this research start? Because I know you worked on plenty in your career, different from the other ones you worked on.
So because first of all, I'm doing a lot of recruitment, or we're part of it. I don't do the recruitment myself, but the research projects I've worked on have mostly been with small groups of physicians, usually sometimes patients, sometimes nurses, who are testing out systems that we're building. Here, we're identifying a large number of people, some 20, 30,000 people now I think we have in our consortium here, and we're providing data from the electronic health record. And we have to extract the data, turn it into the correct format, get it transmitted to the data resource center, and make sure the data are correct, that we're not sending the wrong data, and that we're sending everything that we can send to fill out the research record at the DRC.
Okay, so when I first introduced you, I mentioned informatics. So can you kind of tell the audience that have never heard that term before, what does that mean?
So it's informatics. There's an R in there, I think.
Okay.
So it's really, it's a short word for information science. Many decades ago, the French coined the term informatique, and they were talking about information science. And in the US, we adopted it as informatics. But it's really the capture, representation, and use of biomedical data and knowledge to address issues in healthcare, in biomedical research, public health, and so on.
So how does your work kind of tie into this with All of Us?
Well, I've done a lot of work with building repositories of clinical data and research data for reuse, which is tricky because electronic health record data are captured for patient care. So you have, what test did the patient get? And we don't test patients every day. We test them only when we need to. In research, we sometimes do test patients every day because we're following a research protocol. So the translation of data from the healthcare arena into the research arena requires an understanding of the source of the data, how the data are represented, how they're coded, what they mean. And so I have a lot of experience in that. And I think that's why they asked me to be the informatics lead. And then I've managed informatics teams at my own institution. Now I'm kind of managing teams at a number of other institutions to help them comply with the data submission requirements.
What's been some of your findings so far doing this work?
The finding is really that the people requesting the data don't have a good handle on the challenges facing the people who have to provide the data. So the DRC asks us they say, give us these data. We follow the instructions, send them the data, and then there's often a disconnect where they go, well, we don't understand these data. And we say, well, you've got to tell us what you don't understand. And so there's a conversation. And as a clinician and an informatician, I'm kind of in the middle translating between the two languages being spoken. So that's really the lesson here, is that saying, oh, we've got electronic health records now all through the country. So the problem with data acquisition is solved. We can get all the data we need for research and it's free because it's already been collected. Yeah, not the case. The data, have to be curated. We have to understand where they came from and what they mean before we can try to reuse them for research. So that's been an ongoing experience since my time at Columbia and all through my time at NIH, and it's just being reinforced here.
Okay, so I'm gonna go back to, because we've been mentioning data and DNA. What do you all do to protect this data while it's all being transferred from here and there?
Well, we do a number of things. First of all, we make sure that only the people that have the need to see the data. All right. So we respect privacy of the patient or the participants. When we send data out of our institution, we have a very strong, secure data exchange system that includes encryption of the data and storage of the data in the remote sites in protected storage media. So there's a lot of physical protection of the data, and there's also protection in terms of permissions for access to the data. So right now, for the most part, the only people that see the data are the people that run the electronic health record systems, and they have to see the data because they're building and fixing things. And then the information technology people on the other end who receive the data have to make sure that the data aren't corrupted, or that they got what they needed. But then after that, people are only allowed to look at the data when they have approval for a research project that an institutional review board has reviewed and approved.
Of course, like with this data, it's never shared with, if I'm rewording this question right, it's not shared with is it separated from the doctor, or is it connected together? Like, say if I go in for a visit with my doctor, would it be kind of tied in?
Well, so if you were a patient at UAB or one of the other healthcare providing organizations, you would come in, you'd have a visit, you'd get blood tests done, your doctor would talk to you, write a note, maybe get an x-ray, the radiologist writes a report, you might get a lab test, a report goes in, orders are put in like for medications and so on. All of that becomes the data in your electronic health record. And then the patients in the US have a right to share those data with whoever they want. And the health provider organizations, whether they be a big medical center or a single doctor private office, are required to provide those data in electronic form to wherever the patients want. And I use the word patient because it's everybody. It's you, me, anybody listening to this podcast. So but then as a participant in the study, we ask the participants to agree as patients to have all their health providers send their data to the data resource center. And they do that. Now, a lot of places, it's very difficult for them to do that. They're still trying to figure out how to comply with the law. So your single physician practice in rural Alabama might have an electronic health record, but their ability to share data is going to be limited by that, whatever software they're using. But at a big center like UAB and other partner healthcare institutions, we have a way to pull all those data out and share them. Now, information about the physician, we don't share information about the physicians other than if we have a report that we send, it'll say who signed the report. But we don't say who is this person, where do they live, what's their phone number. We only send data about the patients.
Okay, so I know this is like a 10-year study. What happens with the data from after these 10 years, or what happens if somebody withdraws earlier?
Well, so first of all, so what happens with the data are a couple things. One is that people can, with the proper credentials, can sign on to the All of Us Enclave, which is a computer system on the internet, which has access to the data that's being collected, not just from UAB and other places, but whatever data is collected. If a patient fills out a questionnaire online, the patient gets a blood test and gets DNA sequencing, all of those data are available in the Enclave. Researchers can sign on there, run programs on the Enclave that analyze the data, and then they can get results, summary results, which they can download, but they can't download the individual data. They can only get the summary results. So there's no individual data released from the Enclave in that way. That's kind of retrospective research, because they're working on data that's already been collected. Mm-hmm. And some of those data might be 10, 20 years old, depending on the electronic health record that provided the data. Then the other thing that can happen is that a researcher might say, I'm really interested in studying a certain condition in people who have already are on a certain medication or have a certain variant in their genome or what have you. And so they're going to look in the cohort of data to find people that seem to match their enrollment criteria for their study. And that would be a prospective study going forward. And then with the proper institutional review board permission, they can then contact those people and say, hey, remember you joined All of Us, gave us permission to look at your data so that you could be part of future research studies. And if you're interested, we have this study where we're looking at disease X and you meet the criteria. If you're interested, let us know, we'll sign you up. And then they can enroll people. And they might do that nationally, which might be a challenge if you have to get blood tests and things like that. But if you're doing things online like surveys, you could enroll people across the country. Or if you say, gee, I'm only in Alabama, so I'm going to look for people that are in Alabama health provider organizations, and they can limit it down to that. Then once they do that, then they contact the patients individually with their own research projects. And whatever they do is their own research, their data, just like we do with any research project. Now, you asked an interesting question. What happens if somebody says, yeah, I don't want to be in the study anymore? Well, they can do a couple things. One is they can say, I don't want my data sent anymore. So they can say, you've got my data. I filled out the questionnaires. You got my genetic data. Yeah, okay, that's enough. I don't want anybody contacting me. I don't want any of my new data to go because maybe I have a new medical problem and I really don't feel comfortable sharing it. Or, I just decided for whatever reason, I don't want to share any more data. People can stop sharing data and still allow the old data to be used for research. They can also say, you know what, I changed my mind. I'm not comfortable with this idea of having all my data out there somewhere. And, I don't feel like I know what people are doing with it. And so if they have that, if they feel that way, they can tell the consortiums, please unenroll me. And so now they'll be removed from the study. Now, what they can't do, unfortunately for them, perhaps, they can't tell a researcher who's already accessed data to undo that. So if they've analyzed the data and come up with a summary, there's no way to pull that out of the summary. They also, if researchers have downloaded data because they enrolled those people in a different study, then the use of those data is subject to whatever the rules of that study are. All of Us has no control over that. So if I was, or let's say you're a researcher, a citizen scientist, and you got permission to download a bunch of data, identified people, got their permission, got all their data, and then some of them said, hey, Jarvis, we don't want to be in your study anymore. That would be up to you, and the research subjects to decide what happens with those data. But All of Us has no control over the data we've given to you once you got it.
Now, one of the things I've noticed, which is really neat about this study, is that they gave me a free Fitbit. So how, and just kind of tying this in, so does this give you good real time, the data is there from me wearing the Fitbit? Is it being, what I'm trying to say, simultaneously?
Okay. Well, so Fitbit is a limited piece of hardware. It collects certain kind of data. I used to have a Fitbit. I don't anymore for various reasons. None of them, bad. But I discovered, for instance, that it was pretty good about telling how many stairs I climbed.
Okay.
But if I was in an elevator and I just moved my legs up and down like I was walking upstairs, it counted it as climbing the stairs. So I could get, 100 flights of stairs by just taking the elevator in the Empire State Building and moving my legs while I was doing it. So, it's not, you get what you pay for. It's not a super accurate device, but it's pretty good. And in general, when you have collecting a lot of data like that, you can get the signal out of the noise and generally get an idea. Hey, these people are moving around more, or they're moving around less, or Jarvis is a pretty active guy, but his brother's not very active, or Jarvis has been pretty active, but lately he's not moving around. I wonder if he's okay. Maybe we should give him a call. So there are certain things you can do with it if you know what to do with it, and it's just another way to collect data that doesn't require you to log into a website and go, here's how much I walked yesterday. It just collects it automatically. So it's just another method for getting data about people and what they're what's going on with them.
So with the Fitbit right here, who else has access? It's just all of us researchers that have access to
that. As far as I know, we don't do the transmission of that from the health provider organizations. But as far as I know, any data that's collected between the participant and all of us goes into the same database at the data research resource center, the DRC. And then it's just like having your blood tests or your questionnaire that you filled out or all the lab results or, that sort of thing.
Okay, and I want to go back to the question because I just went on the website because I make sure I didn't miss anything. Will the insurance companies know if you participate in the study, or will that information be used?
So insurance companies aren't notified that somebody's in this study, and we are not collecting health data per se. We certainly don't provide genetic data that we've generated. That's really the only data that we generate. Well, I guess the Fitbit data, I guess we would have that too. But no, we're under no obligation to provide that to health insurance. Now, your health insurance plan may require you to, provide access to data, and they may say, where that comes from. But as far as I know, it's going to be mostly whatever hospitals you go to and doctors' offices, but they don't have access to the data in all of us. That's protected by a confidentiality agreement with the National Institutes of Health.
Okay, so where do you see this program going now that we're kind of getting into the second 5 years of it?
Well, I think that it's a remarkable program for a number of reasons. One is the sheer size of the cohort, which we haven't seen since things like some of the veterans research studies. So we've got a really big cohort, and of course the veteran studies are skewed to certain populations, certain genders. This is a much more, if anything, we have more, too many women and not enough men signing up. But the other thing that's interesting about it is the racial diversity of the population is much broader than somebody may be able to do when they're doing research at their own institution, where they have a research population that reflects the makeup of the general population, and then depending on socioeconomic factors, they may be able to reach or not reach certain parts of that population. Here, there's so much more diversity that when we do research and find results, we could say, this applies to the whole population, not just white men between the ages of 25 and 50, but we can say that this is a much broader, reach for the findings of the research. So I think that's one of the remarkable things about it. The other is that we're building a group of people who have willingly said, we'd like to be part of a research study if there's one that's appropriate for us because we want to help. And I always kid that if there's a gene for people that want to share their information, and there's another gene for people that don't want to share their information, we'll never find that other gene. Okay. Because we can't study those people. But people that are, these people now, we got 1 million people. And if I say, hey, you know what, I'm really curious about something that I need to ask 1 million people about, this is a really good way to reach them, because not only are they willing to answer, or for the most part, but we also have so much other data about them that I don't have to ask them, well, how old are you and what drugs are you on and what's your cholesterol? I could just go, hey, how you doing? And do you have this problem? And then I can look and see in all the other data what correlations there are, or if I want to enroll them in another study, that sort of thing. So that's really remarkable. We don't have anything like that in the United States, probably in the world, where we have that kind of reach to such a broad population.
Okay, kind of summing up and ending, some of the questions I always like to ask all the people that's behind it. Why did you choose a career in medicine?
Well, I chose a career in medicine because my father was a physician. He was a pretty famous physician, actually. Although I didn't know it when I was a kid. He was just dad who made me clean the yard and stuff. But I did learn about medicine from him, and really was interested in the idea. I loved science. I loved helping people, and I loved the idea of applying science to real world problems. And so that was a really good fit. A better question is how I got into informatics. And that was because in high school, computers were just starting to be made available to high school kids. Like we had a teletype. You go look up what that is in the museum. We had a teletype, and I kind of taught myself how to program on it, and got to college and was lucky enough to go to a place back then where undergraduates could take computer science, computer programming. And I found I had a really a good affinity for it. I really enjoyed it. But when I finished college, I said, gee, I still want to do medicine. Maybe I can find a way to use computers. Maybe somebody's thought of this, an idea of using computers in medicine. Of course, lots of people had thought of it, but I had no idea what was going on. I went to medical school, and the whole time I'm in medical school and resident, I was like, oh God, I could do this so much better with a computer. Why am I doing this on paper? Why am I running around looking for a paper record when it all could be in the computer? And why do I have to manually look through all these things to look up articles in the library when I can have a computer system, so on. So when I finished the residency, I started looking, what could I do with computers? And I found the fellowship, and that was exactly what I was looking for. And at that point, there were just starting to be careers for people who were practicing physicians, but also wanted to do informatics. Columbia was one of those places, and I'm a New Yorker and at heart, so it was a perfect match.
So I must ask, since you're a New Yorker, were you a Yankees fan, Mets fan, Giants?
My father didn't follow sports, although he grew up in the shadow of Yankee Stadium, and I never was into sports. But I found out that I was a Yankee fan when I saw a Yankees Red Sox game. And so I'm not sure if I'm an enemy of the Red Sox or a fan of the Yankees. And when the Yankees and the Mets played the World Series, I watched it with my father, and we were just rooting for whichever team was behind because we wanted it to go on to 7 games. So I'm kind of a Yankees fan, but only when they're playing the Red Sox.
Okay. Okay. One question just popped in my head before we close is, do you see anything with AI coming in what you doing?
Oh, sure. Yeah, I see a world of trouble coming from AI. AI. So artificial intelligence has sort of evolved over the years to mean different things. But interestingly, the early vision of it with things like HAL 9000 from that's gone right under my head, 2001 Space Odyssey. That was the original vision, but the reality fell far short of that in the 80s, 90s, and 2000 because we didn't have the computing power to do it. Now it's turning out that we can converse with our computers, but the key thing they need is a lot of data. So we can't teach them how to think. It's too tedious. But we give them a lot of data and let them look at patterns, and they can figure out how to think for themselves, looking at the patterns. So a project like All of Us, where we've got 1 million people and we've got their genome, so we've got 3 trillion or whatever it is base pairs for them to study. Now they have a lot of data to work with, and that's how we build up the models, the computer models that then drive the current artificial intelligence. So it's going to empower artificial intelligence, and then so that's great. We can build toys, but we can also use this artificial intelligence to help us as we start to learn more and more about people's healthcare and what we can predict from their genome, the genetic tests, and also from their electronic health record. We're going to need computers to help us sort out what to do next. We're going to say, gee, I want to give this guy this drug. The AI is going to be able to say, well, doc, everybody else that had this variant in their genome that got this drug died. So you might not want to use that drug. And I'll say, well, why is that? And we'll go, we don't really know, but we do know from all the data and all the pattern matching we've done that you really don't want to do this. And I'll go, thank you very much. What should I use? And it'll make a recommendation. And then of course I've got to verify that makes sense clinically, that it's not, sort of hallucinating or confabulating. But there are going to be tremendous tools to help us apply all the knowledge that we're generating partially manually in, journal articles and textbooks and all that stuff that we've been doing forever, but also the kind of knowledge that's going to be generated automatically just from analysis and machine learning of the data that we have.
Okay. Well, Dr. Cimino, thank you for coming on today. Any other final thoughts? And if somebody's thinking about joining, where they go and reach out?
Well, I think that joining, so people are worried about your privacy, and I think we're doing a great job protecting that. We hear about breaches, we hear about problems where some federal or some government agency says, hey, we want to see these data. People who participate in all of us are not in any danger of having their data released for something like that. And they can participate in this big club that is, sharing data in ways that will improve the healthcare of the general population, but hopefully improve the healthcare of the people participating in the study first. Because as we learn something, when we say, hey, we discovered somebody with this variant should get this drug or not that drug, these are the people we'll be able to tell first because we've got all the data on them and be able to let them know. Meanwhile, I don't know about you, but my genome, don't have my genome anywhere yet. And so I'm going to have to wait for the results of all of us to help me. So I think there's a lot of good reasons to join. And it's not more than just getting a Fitbit.
Yeah. So, Dr. Cimino, thank you. And if you're thinking about joining, call 833-JOIN-UAB or visit the website, all of us in /UAB, or you'll see on the little text from the interview. So, Dr. Cimino, thank you again. Thank you all for watching. Please check out what'shappenedbirmingham.com for more interviews. Don't forget to subscribe to the YouTube channel. Thank you all again, and have a great day, and be a Yankees fan.
Okay, thank you.
All right, bye-bye.
Thank you for watching the What's Happening Birmingham video podcast. Please check out our website or subscribe to our YouTube channel for the latest videos today.